Good morning. My name is Carl Palmer. I'm the Chief of the Safer Consumer Products Branch at the California Department of Toxic Substances Control. Welcome to our webinar this morning, where we are going to highlight some work done by our colleague, Dr. Ali Kamal of US EPA, and he's going to give us a presentation entitled Monetizing Impacts to Public Health, a case study of select air pollutants by the US EPA. Before I turn it over to Dr. Kamal, I'm going to set the scene a little bit and give you a little context. The California Department of Toxic Substances Control's Safer Consumer Products regulations provide a framework for how we in California identify what we call priority products, which are consumer products that contain one or more hazardous chemicals for which we're concerned about because of their exposure to public health or the environment. Our regulations require that once we identify one of those priority products, the people that manufacture and sell or offer for sale that product into California are required to conduct an alternatives analysis. And our regulations lay out a very detailed set of criteria for how you conduct one of those AAs. Last June, we put out a guidance document that goes over the AA requirements and provides lots of different tools, references, guidance, and information on how you would go about conducting an AA. One of the unique aspects of those AA requirements is the requirement that at one point in the AA process that the manufacturer has to identify and evaluate public health and environmental costs that are result from the use of that priority product. So today we have a great opportunity to hear from Dr. Kamal, who is looking at a very specific impact that is, I think, a good model for one of the things that people can look at when they look at our requirements. I want to stress that the requirements are fairly broad and deep, but non-specific, and so the devil is always in the details. But today we're fortunate to have a good example that we think will be very insightful for folks to see how one specific approach is looking at monetizing impacts from air contaminants. So we're very excited to have Dr. Kamal this morning. We're going to have about an hour for him to present, and then we'll have time for questions afterwards. If you have a question, please use the question box on the webinar and type that in, and then we'll have some time to go over those questions. I want to stress that this is just one aspect in one webinar. We have plans to have additional webinars and information out that will build this toolkit of methodologies and information that you can use when conducting an AA under the California regulations. So we're going to have plenty of time today. We're excited to hear from Dr. Kamal. And I also want to just highlight that at the end of the webinar, you'll be asked to fill out a survey. We'd appreciate you filling that survey out because it's really important that we hear from all of you about ways that we can improve the process and how we can meet the needs of people trying to work through the California regulations. So with that, I'm very honored and pleased to welcome Dr. Kamal, and I'm going to turn it over to him, and we'll just dive right in. So Dr. Kamal, thanks for being here, and it's all yours.
Hey, thank you so much for that intro, Carl, and good morning, everyone. Thanks for inviting me. I was asked by Andrew to give this introduction on how EPA calculates benefits in our cost-benefit analysis that we're required to do. Let me start sharing my screen here, and so you'll see my slides here in a second. All right. So it sounds like you all are maybe entering some uncharted territory, but you know, EPA has been doing this kind of cost-benefit analysis for decades now. We typically do it on a national scale, and over the last several years, we've developed tools and are looking at a variety of different spatial distributions to make it more user-friendly. We are asked to give trainings on how we do this, just like today. And we're asked to do them all over the world because really people are, I can't find any other way of saying this, they're just like hungry for this information. They need to know how to monetize their health benefits and provide that information to the policymakers. So just as an intro here, I work at the Office of Air Quality Planning planning standards on the Health Environmental Impacts Division and work in the Risk and Benefit group. Now, there's only really one person that's more senior than me with the benefits. He's been doing this for over 10 years. He was really in the cusp of developing the program and making this user-friendly with the tool that we use. But for better or for worse, you got me today. I've been doing this for about 3 years now, but I remember how challenging it was to pick up because I spent prior 15 or so years in exposure research, mostly doing field work, characterizing sources of PM 2.5 and doing animal tox studies. So I was, like you, thrust into this unfamiliar world of cost-benefit analysis. So hopefully that's to your advantage, because I know at times when I was taught by an economist how to do this kind of work, it felt like I was drinking from the fire hose. There's just so much information out there. The economics terms are often confusing, and sometimes it seems like they're almost intentionally confusing. So I'm going to hopefully communicate this as best I can so it's as digestible as possible and familiarize yourselves with how EPA monetizes benefits, and hopefully you'll find parallels to the work that we do and the work that you're asked to do. So in the end, I'll be happy to take any questions. So first and foremost, as I was going through this, we really have two main objectives that we try to convey when we're doing trainings like this. It's one, explain first how we do benefits analysis on the reduction of ambient air pollutants. I know that's a different component to what you're all doing, but I think it'll lay the groundwork to better understand that second part and how do we quantify those health benefits and compare it with the cost of control strategies. And down below there, BenMap, that's the tool that we mainly work with. That's been developed in-house here. It's a free software that anyone can download, and it allows you to do a cost-benefit analysis on ambient air pollution. So let me just get started here. So why do we even do this kind of work? Why estimate the benefits from an air quality strategy? Because I mean, consciously, wouldn't you just say, yeah, no, improved air quality? Wouldn't the health benefits be there? But we actually have to put a dollar amount to it. Now, what's interesting is that, be very careful politically, we don't actually use costs and benefits in setting the standard, any of the EPA standards. They are really used for understanding better the implementation costs and making the option selections. What informs what we do to set the standard for air pollution is really the science that goes behind it, the evidence. And that's usually compiled in something called the Integrated Science Assessment that people in the Office of Research and Development here at EPA work on. They come out with it every 5 years. I'll go into that a little bit more, but just want to make it clear that cost-benefit analysis really helps inform the EPA administrator on the best options, but it's not used to set a standard in terms of and what's considered healthy for a population. And usually we're presented things when we set the standard of things like controlling for an emission source. It could be something as much as like a $750 million air scrubber on a power plant, or it can go down to as little bit as like, hey, just keep better paperwork so you can look at your emissions and make sure you don't have any problems. So it's a wide range of things that we look at and we quantify, and I'll try to convey as much as possible the process that we go through that we have to use to provide an adequate margin of safety to the public. And one last thing, I just want to make sure that it's nothing that we do here is risk-free. So there's always going to be some amount of ambient air pollution. We can't reduce the risks ever to zero. And just to keep that in mind when we're doing these analyses, we often have to state that as best we can. We just try to do it within an adequate margin of safety. And just to figure on the side there, that's just to give you an idea of the amount of work that's gone into providing since 1990 the Clean Air Act amendments of the benefits that we've seen over the years and how we quantify those benefits. I'll explain later in terms of the cost of those implementations and how effective they've been to the public. All right, so Now, when we look at ambient air pollution, we look at a variety of benefits, both from the health standpoint and the welfare effects that we consider basically environment or secondary effects. So for health, we are really concerned with reducing the risk of early death and chronic diseases, hospital admissions, and also things like school lost days and missed work. If you're sick, you can't attend school. So that actually goes into consideration when we consider in our cost-benefit analysis. And then things like the environment, like improved visibility, crop yields, water quality, all these things are considered. And you may want to say, like, can you actually put a price on these things? And unfortunately for our work, we do have to put a price on that. And so when we start laying the groundwork here, it's really important to understand how this process comes about. We really start by looking at the industrial emission sources, and then understanding that from those emission sources, certain pollutants can be affecting human health. And what I'm going to talk about right now is just particles finer than 2.5 microns, so PM 2.5, and then how that impacts human health. So it's this basic strategy or the main premise of what we do. And with that understanding of that toxicological effect, that actually brings about like how we do all the work with our cost-benefit analysis. So it's basically understanding the emission sources and then looking at the studies and how those emission sources or those pollutants are impacting human health. And just to be clear, when we consider, this may be relevant to you all, that EPA right now doesn't look at any of the specific sources of ambient air pollution in terms of PM or the makeup, the constituents of it. It's across the board. Fine particle matter is the same. We're not trying to divide it up that one has more toxicological effects than the other. Just to keep that in mind. All right, so this is intended to be busy. This is from an adaptation from a publication that was put out several years ago. And this is really to give you the sense of all the toxicological evidence behind of what we do. So, we showed that diagram in the previous slide of, okay, emissions and health endpoints, but do we have actually plausible proof that that's even possible? And a lot of these tox studies do show that when you look at certain PM inhalation, that we can see impacts on the blood and central nervous system and oxidative stress. So there is supporting evidence. So quite often we do use tox studies in EPA, but they are used primarily to show the evidence that are there. We do not use any of those tox studies to try to generalize and make assumptions between health and a specific pollutant. So this may be key to what you're doing here. This may be a little bit different how this differs a little bit from potentially the work that you will all be doing, looking into the tox effects from hazardous air pollutants and toxic substances. So again, this is how we really base our work from the epidemiological literature, We need to quantify the magnitude of the risk, basically. So we look at several studies across the United States and try to identify really the associations between PM 2.5 concentrations or ozone and the health endpoints. So it's really the heart of what we do is to understand this concentration response function is what we call it, or health impact function. And basically what we're trying to understand is that when we see a change in PM or ozone and what that change in the health outcome will be. And just so you know, I've been trying to emphasize this PM and ozone. It's really because those are the studies that we have the greatest information on, those two pollutants. So even when we're asked to reduce, let's say, NOx emissions or some other pollutant, SO2 from its power plant, when it all comes down to it, we are really going to change that NOx or SO2 down to particles, so ammonium nitrate and ammonium sulfate, and understand how that reduction in that contribution of PM 2.5 impacts health. And that's really where the strong evidence lies. And even with NOx, it's that precursor to ozone formation that we're reducing. So again, the PM and ozone are well studied across the US for many decades now. And those concentration response functions have been well established, and there's hundreds of studies that we can rely on and count on to help us understand that relationship. Now, this is a simple markup of what we try to look at. Here's a log linear scale of PM concentration and an incidence. So let's say mortality. We can look at a study. Will look at a city or multiple multi-city study and trying to understand when we see certain higher either hospital admissions or mortality, what the PM concentrations were within a certain period of time. And that could be annual, that could be daily as well. For ozone functions, it could be even within a day time period. So what we're really trying to understand here is the relationship with a change in PM 2.5 in this case, and how that can associate to a change in the health endpoint. So this equation is really a fundamental part of our health impact function. It's associating that linear relationship there, or log linear relationship, with a change in a pollutant. And then we multiply that by the population and the baseline incidence. So if you're looking at death rates, you would be looking at the death rate for a city and then multiplying that rate by the population, and then using this function to associate the number of deaths avoided by that change in PM 2.5 or ozone. If this was in person, I would say, okay, does anyone have any questions? But we'll pause that if you need to write down a question or anything. This is really the heart of what we're doing here. And I have another picture here from our BenMap program that hopefully will add a little bit, shed some more light on what we do. So we have the first on the far left is an image of Detroit, Michigan. And we have worked with our computer modelers, our CMAC modelers that can generate these air quality surfaces of a change in PM 2.5 under a control strategy. So we usually have in our rules, we usually look out several years in advance. So let's say we're looking at 2025, and we want to develop a control or strategy or policy scenario for 2025 and reducing the level of risk from PM 2.5. We compare that projected change in PM 2.5 with a business as usual scenario. So let's say there's no rule. So your business as usual scenario will actually have the higher amount of concentrations, and your policy scenario is that lower amount. And so that change is the business as usual minus the policy scenario. So how much PM 2.5 or ozone will be reduced over that time in that projected year. And so we have that in this model over Detroit at a 1 kilometer grid cell. Now we can also we also need to consider from that equation down below there is looking at the population. In this case, we had 1 kilometer population. The 30 to 99-year-old age range I have written there is because certain number of these health studies look at an older population, especially for mortality. When you're looking at 29 and younger, the rate is so much different than 30 to 99. And a lot of the hospital admissions data that we look at with these EPI studies are 65 to 99-year-olds. So really to know your population and your affected population is important. And the last key to this equation is that baseline incidence data. And in this case, in the city of Detroit, that data is available at the zip code level. And so really what I often describe as, quote unquote, the magic of BenMap, it's really looking at that geospatial layering of those 3 layers and calculating the health effects at a 1 kilometer grid cell. So it's basically area weighting that baseline health incidence data and calculating at that 1 kilometer grid cell that effect estimate or that response to a change in PM. And so from that, we can, at 1 kilometer, we can look at premature death, hospital admissions, ER visits, any number of things if we have that concentration response function. Again, this is a good time to pause and but please, I'll be more than happy to take any questions at the end. I know this was really hard for me to first understand, especially without a strong epidemiological background. But this is really the groundwork for our benefits work. All right. So what goes into choosing one of these studies? And again, I mentioned the integrated science assessment a little bit ago, and that's really developed by a team here at EPA that it's basically every 5 years they are required by law to generate this basically the state of the science for every single one of our national ambient standards. So for PM, we have one that they're working on currently, and the previous one was in 2009. So that was a 1,000-page document that looked at hundreds of studies, and really they're trying to evaluate which studies have best identified the associations with PM and the health endpoints. And so there's a certain number of questions that they consider and whether or not to have that study incorporated in the integrated science assessment. And for our work too, we have some certain minimum requirements that we would want to use for our benefits analysis. And we would prefer studies with populations that reflect well, that are reflected well. They're not just like these isolated studies in a small community, and there's a sufficient population size and multi-city. And hopefully one day we'll be looking at multi-pollutant models too, not just single pollutant as we're doing right now. So this is the integrated science assessment. Again, it's a compilation of a lot of work that's been done over the and really gives us the groundwork for developing these new concentration response functions that we look at. And this is the pyramid of effects. And so we often show this to help people visualize the endpoints that we're looking at. We kind of pet name this the pyramid of doom, where death is on top really with the severity of the effect, but the magnitude is probably the least. And as you move down the pyramid, a greater number of the population is affected. But also, the magnitude is less. It goes down from death to ER visits to hospital admissions, down to just showing respiratory systems or just having even some minor inflammation. And that air pollution may have a effect on a larger population, but even in the millions of people. But really, the way what we do is with quantifying benefits and then monetizing the benefits, we see that death attributes to always over 90% of the monetized benefits. And I think that's really what you're after today in terms of understanding how we get to that point. How do we monetize benefits? But I first feel like we need to lay the groundwork for that. And let me just summarize this part by giving you an example here. This was a study that we worked on with a 10-county region in South Carolina. It's the area called 10 at the top. And they were within their attainment for ozone and PM, but they were getting close to being in non-attainment. So they were close to violating the EPA standard. So what they wanted to do was develop a strategy, mostly voluntary strategy, of what they can do to reduce their emissions that wasn't a heavy lift. So they were trying to find out how could they get the greatest bang for their buck, basically, and looking at PM, ozone, and toxics all together to see how they could reduce their level of risk. And so what we were able to do with them is that they worked on a plan. They came up with a strategy, and we helped quantify those benefits in terms of premature mortality and hospital admissions. And then we helped them also with our bed map analysis to value that and put a dollar amount to it. And so you could see any kind of premature mortality, the value is exceedingly outweighs any other value there. I mean, it's really the driving force here. And what they came up with was actually a $20 million strategy, and so the benefits far outweighed the cost in this case. So this is something that they were wanting to take on to really show to their policymakers, hey, what can we do to stay within our standard and show good faith effort that we're trying to protect the public as much as we can. There is a paper that came out with this work that I could share if anyone was interested in a similar analysis. So now I would like to get into monetizing our benefits. So I showed you a little bit about how we understand that health endpoint. Now, how do we get to avoided death, or how do we get to avoided hospital admissions? It's really understanding that change in air quality that we expect from a control strategy, and then looking at the population affected. Usually we look at across the whole US, and then understanding that baseline health data. And all that goes into getting you a number avoided hospital admissions and avoided mortality. So now monetizing that, we have two different strategies that we look at that. It's the cost of illness and willingness to pay. Cost of illness is really, it's just straight up, how much does it cost to go to the hospital? And how much does it cost if you can't go to work? And how much money would you lose if you had to stay home with a sick kid? So it's a straight value that is helps inform decisions, and you can apply that to a straight understanding of like, okay, if you have this many hospital admissions, use that multiplier. But willingness to pay is a little actually more recommended because it gives you more of an understanding of pain and suffering that is associated with an illness. It's not just a dollar amount. There's a lot that goes into an illness. And I actually have a good, on the next slide, a side-by-side comparison of these two. So with cost of illness, you're looking at direct dollar values, whereas willingness to pay comes from revealed or stated preference of how much people are willing to avoid a risk, or I should say, there's another way of saying it, of like the preference of risk reduction. We're getting into economic speak here, so please bear with me. I'm doing the best I can to make it as clear as possible. So with revealed preference, this is driven by the labor markets. So basically, you're trying to understand if you had a job that was very risky. They are looking at all those jobs and trying to understand how much did that person decide that job was worth it to them to take that higher risk job. So in that picture on the side there, that was just to demonstrate, are you the guy climbing the smokestack, or are you the guy in the van calibrating the equipment? So if you're the guy climbing the smokestack, how much more did you want to make that worth your while, to put you in that level of risk? Stated preference is basically, it's in the contingent valuation. Again, doesn't need to be that complicated. It's basically a survey. How much would you, if you were asked, how much would you want to avoid getting sick? That is then put into a study as well. So these two things, revealed preference and stated preference, goes into that willingness to pay amount. It's not just a straight up dollar amount for going to the hospital. And again, this is generally more uncertain, but it's actually preferred when we do our benefits analysis and monetize those benefits. Okay, so again, here, asking economists can lead you down a road that you may not, leave more confused, as I often was when I started asking questions about this. So when asking an economist what's important for economic evaluation, the first response I would get is support for estimating marginal changes in health outcomes. That's basically trying to understand a linear relationship. That is what I showed earlier with that log linear relationship. As concentration goes up, you see incidence go up. It's generally not used to use reference dose or reference concentration. That's more of an absolute value and binary, so it's hard to associate a relationship with just those single values. And then the second question here, hopefully this is all useful to you, focus on health endpoints that are able to be valued by the individuals. So hospital stay, ER visits, that can actually get you a dollar amount. FEV1 or blood pressure, a numerical number like that, or numerical value with that information may give you a relationship, but it's hard to put a dollar value on that. Understanding the time course of disease development, basically reduction in your risk may not happen years out. It may not be immediate. And so that actually comes into play with something called discounting that if you have questions, I can answer those later. Basically, you won't see the impact until years out. So is it worth it to you to have that control strategy? And then we should strive for estimates based on total willingness to pay. Again, that's just you get a more comprehensive estimate than just a dollar amount. And the last one there, you need expected values of outcomes. Even still, I don't know how to explain that other than get an economist to help you, because I don't know how one would get to that point without having that background. I recently had to go to an epidemiologist because someone with our BenMat program, international user, had a question for us. She was seeing something like 17% of her cohort in her population were dying from air pollution. And she was saying, is that a reasonable number? Well, showing the evidence for that number to a epidemiologist provided that support for that value. I think that with an economist involved in the mix would help probably basically generate the plausibility that the numbers that you'll be producing are valid. And I would say that is helpful here too when we're adjusting for those values. Although this is simple arithmetic, that sometimes may not be things that you consider. So when we did some of these, well, not EPA personally, but a lot of the compilation of these cost of illness studies early on, the studies were taken from the 80s and 90s and adjusted for dollars in the year 2000. So let's say a room charge in the year 2000 was $10,000, and then again here in 2018 or in 2008, this was the last time it was adjusted here. You know, the median consumer price index, basically, again, just saying simply inflation, you multiply it by 140% for the year 2008, you get $14,000. The other thing that we come out with is the amount of lost wages, again, that median daily wage increase, as well as a wage index to 2008. So the inflation on top of how much wages have changed in that time. So there's two components there that in that economics, someone with an economics background would have a better understanding of helping you get there. But these are things that we often use and are currently built into our tools that we consider every time we do an analysis. Another important thing is this estimates for growth income. And that is basically as you have more money as you get older, typically, you'll be willing to spend more on your health, if that makes sense. So it's basically, so your willingness to pay in 2000 is $43 for an avoided asthma attack. Income growth adjusted to the year 2020, so basically inflation is that, and then cost year adjustment is that. I'm sorry, the cost year adjustment is that inflation rate to the year 2000, and income growth adjustment for 2020 is if you did have income projected to that year, that amount, if your willingness to pay now is $43, it'll be adjusted to a higher number later when you have a greater income on average. All right, so if there's anything economists can help you get through all that, I would say just keep one around to explain to people the value of statistical life, because this is not something that is easy to explain, and it's actually quite controversial as well. I'm going to do the best I can here to make it as simple as possible. So what we, from what I understand, we often use this example here when we're doing our training. So imagine a population. Now you're an individual in a population of 10,000 people, and you want to reduce you're asked to reduce the risk of one premature death in that population, and you come to the fact that you are willing to pay $500 to reduce the risk of death by 1 in 10,000. So for your life and the lives of all the others in your population, you're willing to spend $500 annually that everyone in that population of 10,000 has a reduced risk of 1 in 10,000. And from that, if you have a population of 10,000 and you multiply that number of $500 that everyone on average is willing to pay, you come out with a value of statistical life of $5 million. And so again, this is not the value of life that anyone has put on or survey data or anything like that. This is a calculated amount that, again, from the willingness to pay of $500, that was taken from those studies that were done. We used 26 different studies. 21 of them were those wage studies of increased amount of risk. How much more would you want for that increased risk? And then 5 of those 26 studies were stated preference, so that's surveys. So it's a compilation of all those studies that were done, 26 of them, that went into EPA's value of statistical life. Again, hard concept, and I will expect some questions at the end. So, yeah, without an economics background, let me show you the stop sign thing here. So this is really, because it's such a hard concept, I was trying to think of ways in the past to like explain it as simple as possible. So I was once driving out in the middle of rural Pennsylvania in a field study and saw this stop sign in the middle of nowhere that had blinking lights in the solar panel. And I was just like, something bad must have happened here because this is really out of place. And this is the first time I thought, oh, this is a value statistical life situation where they valued that everyone in that small community should put in some money towards taxes and put in that stop sign because that would avoid a mortality situation or serious hospital admission from an accident, as they probably have seen in the past. So, you know, it's not a perfect analogy because, you know, there's taxes and air pollution is more ubiquitous, whereas stop sign you'd have to be driving. So I've been, you know, economics professor didn't quite like that example as perfect, but I feel it serves as an analogy that if inserting a stop sign there would avoid a case of hospital admissions or death, then that was the amount that community felt was worth putting in, and that was their value of statistical life. They did that analysis, for example. All right, so we're using the right VSL or value statistical life. Again, it really comes up to over 95% of the dollar value of our benefits and all of our regulations that we've seen. And so it's quite controversial from those, especially in industry, that may find it quite challenging to compete with that value when you're seeing you know, a certain number of avoided deaths from a reduction in PM 2.5 or ozone. Any reduction strategy is the benefits can far outweigh the cost. We do, as I mentioned, you use a single VSL here that's adapted from 26 studies, and they were mostly from the wage studies and the survey data, as I mentioned. So we have the table on the bottom is the income growth and currency year, both things that we consider when we're trying to calculate our cost-benefit analysis. So if we do a projection of the year 2020, and the rule is supposed to be implemented in the year 2010 or 2015, that's how we would adjust that our VSL from that previous study to give a strongest estimate of the VSL that we would use in our calculations. All right, so there's a lot of things to consider and a lot of issues that we often run into. For international users of MMAP, they often ask about this because our value statistical life is far different than developing countries. And so how can we adjust for poor countries but also too the elderly that are older? How can, you know, if they may, we get challenged at times, like, are you actually reducing a risk, or would this person have died anyway from a similar illness? Are you actually capturing correctly that that association there? And things like, you know, are you actually protecting things far in your grandchildren's generation? Should things be discounted? And I could discuss that if you want. Like as you go on, your willingness to pay for improvements gets reduced quite a bit. At least that's what the studies have shown. And how you do things that you can't put a dollar amount on, should somehow they be counted anyway? And is it better to include very uncertain values with a wide range or nothing at all? With VSL, we always do 95% confidence intervals. So if we're even seeing deaths of like 10 deaths and that attributed to like 100 $100 million. We put these large bounds on that value to make it clear to people that, yes, we are trying to capture the uncertainty as best we can. And another thing that has come up recently is our all deaths should have the same VSL. Someone with a willingness to pay questionnaire, they may see cancer risk as being incurring far more greater pain and suffering. So their VSL for cancer death would be maybe greater than a cardiovascular heart attack. So death. So those things are also being considered when we're looking at the VSL. And it's a slippery slope when you start talking about the VSL, because there's a lot of, you wouldn't think about it, but there's a lot of different opinions in the economic world. Because we were asked a few years ago, in early 2000, by the Science Advisory Board, EPA, to look at as people are older, they should not have the same value of statistical life as those who are younger. And EPA got a lot of trouble for this back then, and there was a lot of controversy because we're basically saying those that are older have less of a value, and that's not actually the case. But because it was perceived as such in the public, ARP that represented 35 million people were trying to say like EPA is not valuing human life of our elderly. And so eventually, within the first few months of this announcement, it was done away with. There's just too much controversy. The perception was far. There's such negative perception that we can't do it. Now, the World Health Organization uses things called DALYs and QALYs, the disability adjusted life years and the quality adjusted life years. Those are numeric values that consider age and how many years you still have to live. But those also have their controversies as well. And if you have questions on that, I can go into that a little bit later as well. And again, as I mentioned, we try to capture the uncertainty. We always bound things by the 5th and 9th percentile to characterize that uncertainty. We have looked at several, I would say probably now hundreds of studies that associated PM 2.5 and adverse health outcomes, and we summarize those as best we can and trying to understand where the studies we have chosen fit, and we try to use those that are most in the middle of the road and are most widely accepted. And we often do sensitivity analysis to show that we're not just using studies that are, unique and giving us a higher estimate. We do look at we've looked at panel studies and try to find studies that we've used, especially for mortality, fit in the middle of the road. So again, certainty characterization is important when we are showing our monetized benefits. Now, in summary, we just want to make sure, this idea that health is worth a lot, especially when it comes down to avoided death. If you can have an avoided death, you're looking at millions of dollars, and that is really where we see the greatest impacts when we're considering the benefits in these cost-benefit analysis. And so when we're looking at other impacts right now, we're looking at things like heart attacks saves about $225,000, hospital admissions 17 to 46,000, asthma attack about $60. So quite a range there. And really the evidence for VSL and supporting that, it does get attacked quite often, but we really have found that it's our advisory boards do support it. It's definitely always challenged, but it is supported. And so hopefully that's of use to you in your analysis as well. So I just wanted to show one more time that graph there of the benefits outweighing the costs, similar to what we're seeing here. This is the Clean Air Act amendments from 1990, and these are the 20-year and 30 years out, how many avoided lives lost did we see from our calculations. So 160,000 in the year 2010, we're expecting 230,000 avoided deaths from not just PM 2.5, but all the pollutants that we regulate. And you can just see down the list there how many are the health impacts that we're looking at that are avoided based upon the Clean Air Act amendments. So that is normally where I do a little summary, just giving you an idea of, like, first we look at how we monetize these benefits. We first try to give you understanding of, we need air quality modeling. We can use monitoring data to do certain scenarios and estimate if we did reduce emissions by a certain amount, hypothetically what that would look like based on our monitoring data. But basically, for how we calculate these, we have to first have air quality surface that we model, look at a change in air quality. Then we look at our epidemiological body of work and understand the best concentration response relationships to use to predict what that health outcome would be using our concentration response function calculations that we have built into our programs. And then based upon all the economic studies that we have, and Value of Statistical Life, we try to quantify those benefits. All right, so here's where I normally would leave off when we do these background presentations for people, especially on the state and local level, where we are looking at helping them with their analyses. But I just want to say, like, I've recently looked into what your program is trying to develop, and I asked some of our toxicologists on hand, and they actually did a case study with the benefits and cost analysis of a hazardous air pollutant years ago. All right, so let me give this quick rundown here. So back in 2001, our Science Advisory Board at EPA asked EPA to perform a cost-benefit analysis on a single hazardous air pollutant. Benzene was chosen because it had the most data associated with it. Houston was chosen as the study area because it would have had the greatest impact. And so what was really going on is in Houston, with the Clean Air Act amendments, they were going to reduce the level of risk of benzene exposure from 2 in 10,000 down to 3 in 1,000,000. So there's going to be a huge reduction in benzene in the Houston area, basically. And we wanted to know, what are the health benefits going to be associated with that? So we as EPA told them, the Science Advisory Board, well, we don't have the studies, we don't have the concentration response functions to do that. And they said, well, do it anyway. Find some way to do this. And so a handful of scientists at the time, with some help from a contractor, found that there was a study from Crump et al. In 1994 that did a study in pliofilm plants, so basically plastic wrap plants, and the onset of leukemia in the workers at 2 of those plants. And so Crump et al. Found that there was actually a gradient, a difference between the amount of exposure and the onset of leukemia. So there were 2 data points. And from those 2 data points, they developed a concentration response function. Again, from what I said earlier, that is not the recommended way of doing it. That is not how we do things with our ambient air pollutants. But this was a one-off study to see if it's feasible to do such a study. And that's why I want to show it to you now that we did take on this approach. So there was going to be some air modeling to show where the reductions in benzene were going to occur. And so they did this projection from the year 2000, year 2010, I believe, and tried to show where the gradient was, where the reductions were going to take place. So with that, along with the change in that concentration response function, they were able to do a cost-benefit analysis of benzene. And see, they've developed that air quality. I just want to make sure I cover everything. They use the National Emissions Inventory to create that air quality surface along with modeling. And let's see. And what they found here was that they were able to quantify the benefits in terms of fatal cases of leukemia. So in the year, this was to be implemented from the 1990 Clean Air Act. So they looked at 2000, 2010, and 2020. And so they did a cumulative estimate of the avoided deaths, because there's only fractions of deaths per year that were avoided. So I think in the end, they it amounted to 1 to 2 avoided deaths from leukemia due to benzene exposure in Houston in that time period through 2020. And they also captured the non-fatal effects of leukemia as well. And that's that middle column there. And then the total benefits is on the far right there. So this is feasible. It is possible. And they looked at benzene in Houston. More of that information I have here under, this was a prospective study on the benefits and costs of Clean Air Act. You can reference that online. And we also have more of the EPA guidelines preparing economic analyses that you can refer to on how we go about it. So if there's anything that wasn't quite clear, like for example, VSL, you can refer to that in the EPA guidelines. So hopefully that has captured a little bit of what you were all looking for. And I will take a break now and wait for some questions.
Thanks, Dr. Kamal. This is Andrew King at DTSC. We wanted to thank you again for the presentation. Hopefully our audience has found it pretty helpful. So next we're going to jump into some Q&A. And Dr. Kamal, I'm going to leave the slides on your screen in case you have to flip through them. So we're going to leave control with you, but I'll go ahead and read off some of these questions that we received. And for everyone that's listening, if you have questions, you can enter them in the questions pane. It should be on the right of your screen in the webinar control panel. All right, so the first question we have is, have you monetized health impacts for lower VOC indoor paints?
Let me see. Indoor we have not done. VOCs are very tough to monetize and quantify. The supporting health information has not been there that we have used even in our ambient air standards. The studies that sorry, there's a little bit of feedback. I'm just hoping everyone can still hear me.
We can hear you.
Okay. So the only thing I can say about VOCs is we've tried to monetize them in the ambient air context, and it's been difficult because the modeling there it's very hard to associate what we're seeing in ambient situations, especially industrial processes near refineries and oil and gas facilities. So indoor VOCs, there may be studies out there, but we have not looked at those as far as I know. There may be more in the tox study realm, but I can ask our epidemiologists here if they're aware of any. At this point, I'm not that I'm aware of.
That's great. That's helpful. Thank you. The next question, this refers to one of your early slides. It asks, why is your affected population only for 30 to 99-year-olds? What about the under 30-year-olds?
Yeah.
There's a second question that's related, so I'll just read it off. It asks, it seems that looking at 30 to 99 compared to school lost days is not consistent. Can you please explain that?
Yes, absolutely. So we look at we have looked at dozens of studies, and each has their own cohort in their study. So the 39-year-old study was developed by someone I know by name, like a Lapule study that we use for mortality. That is looking at all-cause mortality for 30 and 99-year-olds. That we look at in terms of mortality, and the other mortality study we look at is 25 to 99-year-olds. Now, we're not trying to compare one study versus another. We're trying to provide a range of mortality studies. We do have some that even look at 0 to 99-year-olds. So those do exist. But what we're not trying to like lump everything together. It's basically we have an air quality scenario that we're trying to capture the benefits for. So that's going to affect school children. So we have some studies that are 5 to 17-year-olds that we look at. We have some that are infant mortality, 0 to 0 is our age range for those. And we have asthma studies looking at 0 to 17-year-olds. So we try to capture a breadth of different health endpoints and look at a variety of population ranges. So it's not necessarily comparing one study to another. We're trying to get a broad range of studies.
Thanks a lot. The next question we have says, how does willingness to pay account for the uncertainty that the health effect in interest is caused? wouldn't people be willing to pay less for an effect that is uncertain than for something that is much more well established?
Yeah, that's a good question, and actually that comes up to something in terms of uncertain is for sure something that we have to consider in our analyses. Uncertain in terms of not only will it actually happen, but will it happen to them when you're considering a risk reduction. So I would say with the willingness to pay, yeah, I think the surveyed questions or the stated preference questions that are asked in those studies help kind of identify a personal aspect of what they're willing to pay. And then what we do at EPA is something called discounting. So as you go years out, so if you try to create an air quality control strategy now, but you're not looking into the health benefits until the year 2025 or 2030, I mean, I don't know how to explain it other than like people kind of lose interest in that health benefit so far out. So there's something that we have to incorporate to reach this, to answer this question of uncertainty. It's really, as you go further out, are you really going to be impacted by that policy change? And so our values are reduced or quote unquote discounted by different levels, by a level called, well, we have, there's two different levels, 3% and 7% discounting. So for example, if we find that a health benefit is $500 million in the year 2018, that actual number is reduced 3% to a certain number and annually. And so in the year 2030, that $500 million actually has a value of only $250 million. And then 7% discount is even more so. It's kind of like the skeptic out there, like that $500 million is only going to be worth like $100 million. So we have to consider those discount rates in terms of uncertainty years out and whether or not that's there's a true benefit there. I hope that makes sense. It's a topic that I can explain better or share more information on later if that individual still has questions. Hopefully that suffices.
Thank you. The next question we have is, I just checked on PubMed and particulate matter mortality returns over 3,000 studies. So the case example has a lot of data that can be used for costing. What would your advice be for dealing with a much less studied chemical health effect combination? For example, if the data are limited to case reports or limited cross-sectional studies.
Yeah, good question. I think that's really when I heard about this this effort. I think those were the ones that were going to have to be used. These those kinds of studies, because yeah, the evidence isn't quite as strong as they are for PM and ozone as well. See, I definitely yeah.
I'm sorry.
Very hard.
Yes, this is Andrew King at DTSC. So, and just to give a little context here, you know, when we set out to find this a speaker for the presentation today, what we were looking for is a case study that of expert practitioners that did a very thorough job, right? And so hopefully you saw that today to get a sense of what that looks like. Now, a function of that, of course, is this is also a case study, as the commenter points out, that these are impacts that are very well studied with robust sets of data. So the question comes, yeah, what do you do if the data isn't nearly as robust for your product chemical combination? So I just want to communicate from DTSC, that is something that we're considering, and that's something we're thinking about as we put together additional guidance moving forward. But again, for today, we kind of wanted to start with, you know, what does this look like when you have the data and you put in the effort to do a really thorough job? And so that's what this is supposed to illustrate.
All right. Thanks, Andrew, for bailing me out there. I appreciate that. But yeah, I think the benzene example may be the best where that we have available right now where the evidence isn't quite there. We do have studies on sulfur dioxide and nitrogen dioxide compounds. Again, we don't really focus too much on that because the health associations aren't quite there as much. Even with those, we look at how those translate into PM 2.5 and ozone formation to calculate our benefits. I could definitely look into other studies that may be relevant that we use here, but we don't primarily rely on those.
All right, so we have one more question here. So this is the last call for everybody listening. If you have additional questions, oh, here they come. All right. So the next question is, great presentation. I realize your focus is on chemicals, but are you aware of any studies or means of monetizing health impacts associated with changes in disposable income or economic status? Okay, that's a little bit of a different realm. I don't know if you have anything to touch on for that. Don't feel like you have to. Go ahead. So Ali, do you have anything to add there?
Yeah, I'm sorry, the monetizing changes in what? I missed it.
As for monetizing health impacts associated with changes in disposable income or economic status.
Oh, I see. I would say the economic status is something that we are faced with when we talk about our work in international settings, and they have to set their own Value of Statistical Life. I mean, some countries do adjust the economic status based upon our value and just do like a dollar for dollar conversion to their currency. But that's different in terms of hedonic wages and survey data. So I would say that the survey data may be the best way of understanding that better. How much are people willing to spend based on a lower income versus higher income? But there may be more studies out there that I'm not aware of that look at that, or more recent studies too.
All right, and the last question is for DTSC is, will this PowerPoint presentation be available for everyone to look back to? So we are recording this presentation, the slides and the audio, and we'll be posting that to the Safer Consumer Products website. So if you Google DTSC Safer Consumer Products, you're going to be brought right there. And we have a tab that lists all of our prior workshops, and you're going to find it right there. So, and that is part of the goal of what we're doing today, is to build this knowledge. So in the future, potentially regulated entities can come and look at a series of guidances from us. So if we don't have anything else, Dr. Ali Kamal, we'd like to thank you again for your presentation. It was very helpful on our end, and thanks to everybody who attended and joined us today. Okay, thanks again.
All right.
We're going to close out.
Thank you.